We talked about hammers before, okay? But similarly, there is a benefit to know your tools. Tuning fork, for example. What's the frequency of the tuning fork used for for vibration testing? 128 or 64, and then you use 256 or 512 for the hitting, because the hitting range, what's the range of hitting? 20 to 20,000, but what's the normal cutoff for most people after age 30, 40? Usually about 500, or rounds between 200 to 500. So if using 64, 128, it may be expected that they will not hear those tuning forks at all, even normally. Okay, that's the reason. And then similarly, the vibration for the nerves, they have trouble, they have a quicker drop off the higher the frequency. So the 512, so if you had 5 different tuning forks going on the same nerve, let's say, then the 512 will be the first one to be lost, then the 256, then the 128, then the 64. So the lower the frequency, the longer the sustain or presence that vibration can feel based on the mechanoreceptors that are picking up the vibration. Okay? So it's important to know your tool so that you don't get confused. But vibration, the way we test vibration, I'm just talking about tools here, is presence or absence. You can also look for decay, so you can vibrate it, you can put it there, and then you're feeling it in your fingers while holding the stem. Remember, hold the stem, don't hold up here. That's what's supposed to be vibrating. Okay, so you always hold the stem, and so your fingers are picking it. So you hold it there, say, tell me when it's gone. And then at some point, if they have a sensory loss, then they may say, oh, it's gone, but you're still feeling it, so you already know it's abnormal. Or what you can do is compare. You say, okay, you have a distally, you say, okay, it's gone. You walk it up. Say, do you feel it here? It says, maybe you walk it up here. You still feel it, or you walk it up here. And if it's a length-dependent neuropathy, which is most common, then you will see that once they feel the loss here, and it's still vibrating slightly, you move it up and then they feel it again. So we try to create with some sensitivity rather than saying all or none. Present and absent, that's one, but then you say it's present, it's not completely absent, but it just cut off or dies off sooner. So one way is to compare it to see that it dies off distally sooner. Or the better way is to have this tuning fork, which will give you a score of when it dies off. So the junior residents who have not seen this one before, once you vibrate it, the same single triangle ends up creating 2 lines. And their lines are intersecting. So there's a true and false image, or both a false image. And they're intersecting, and the intersection walks up. Okay? So it goes from 0 to 8, and normal is all the way up to 8. Lower the score if it disappears, when it's still at 2 or 3, and say where the lines are crossing, and they say, oh, I don't feel it anymore, you can give it a score. You can say the vibration is 4 or 3, the worse it is, the lower the score. The lower the score, the worse it is. Okay? So you can use tools like that, and similarly there are tools that have been defined. Dr. Fernandez uses dynamometer, which can actually give a score to the strength. So you're pulling the bicep, but not by yourself. You put this machine in between that measures the tensile strength in Newton, and you're pulling on the machine, and the patient's pulling on the machine, and where it starts giving out, the machine marks the highest force created by the bicep, and it says it's 56 Newton on 65 Newton. In a normal scores, it goes all the way up to 100. And similarly, but there are a few muscles you can test that way with the dynamometer. He used to use that a lot in VA. I don't know if he does it now. And you can actually grade, and you can see the loss of strength more sensitively, rather than saying from 5 to 4 to 3 to 2 to 1, you can go from 100 to 89, 82, 85, or something like that. Okay? So I said I will talk about things I carry around, used to carry around with me, I still carry around, so things that are not very commonly used. So Maddox rod, red reflex, very good for diplopia, double vision testing. What you do is that if you put on one eye, and they're having binocular double vision, then it makes one image red and the one image normal, and then you can start telling them if the images are coming closer, moving around, if one is twisted or tilted. So I had a patient with a median thalamic stroke who presented with a fugue, an acute fugue, but if you look at the triad for the median thalamic infarct, it causes an acute fugue that lasts for 8 hours, but it also causes inversion of the eye. One side becomes inverted. There's a triad of it. So you can pick up, the patient says that I have double vision, but the one vision is actually angled. not straight line. And these Maddox rod actually has lines on one side, which can give a feeling of lines, and then you can actually have them tilt their head to see where they start matching and when the angle correct and does not correct. So this kind of tool can help you with that. I used this a little bit towards the end of my residency because I was doing some movement disorder electives. This is a goniometer. It is to measure the joint angle. So if someone has a joint restriction or spasticity, so you put this angle and you measure what the angle is for that elbow, and then you move the arm and you move it with them and see what the maximum they can reach. Okay, there's a smaller version with this pocket one that you can carry with you. This is a bigger version for the goniometer. Pocket cards, we talked about it. We have a different one. There's even one that we used to get which has the color deficiency. You know, this is one thing that we miss often when we're testing eyes. They say that the red-blue color vision is like 10%, red-blue color blindness is 10%. One of our faculty, I think he doesn't hide it, so Dr. Fernandez has red-blue blindness and a color vision problem. So you can look for these cards that you can carry around your pocket, which provide these simple tools like that. Okay, what number it is, and you can check the color vision right there if you're suspecting for some reason. Remember, the first thing to lose in an MS attack in optic neuritis is color saturation, right? And then contrast sensitivity. So these kind of cards can help you right there if you're thinking about it, if you're really thinking that sharp. So if you have it handy, you can use it. Optokinetic strip, I used to use that. Again, I started using more and more of these tools. You know, the more senior I became, I started becoming more comfortable in testing these things. But we talked about Dolkane testing, and you know, you can practice and see. Remember, for the junior residents, the normal response is a slow drift in a saccade. So pursuit followed by saccade. So if you ask them to follow the lines, so as the red line or white line go by, the eye starts tracking the line unconsciously. So there's a slow pursuit or drift. And then when they realize they have to look straight, it corrects and there's a saccade. So that's a normal phenomenon, drift and saccade. The abnormality in OKN is loss of saccades, loss of conscious correction. Okay, so it just drifts and drifts and drifts and drifts and doesn't jump, or it jumps irregularly, or very slowly, or not very frequently. But normally it should follow each line and jump back to the next line. So every red line. So it should be very quick depending on how fast you're moving. You can see very fast saccades or very slow saccades, all following your eye. So normal saccade is that jumping back to each line as it coming up, each red line or each white line, whichever you ask them to follow. And abnormal will be that they miss 2-3 lines and they jump to the fourth one back or fifth one back. Okay. Remember, the first saccades to go in neurodegenerative disorders such as PSP are vertical saccades, not horizontal. And it's usually the upward saccade that's gone, not downward saccade. So they will drift down and they won't jump back up. So that goes up first. That's the smaller one, by the way, goniometer. So this is my black book of exam tips and tricks. Dr. Torres used to throw so many tips or tricks of examination that I used to, I didn't have a place to write, so I carried this. I still have my notes in there from when I did residency, so it's half full. It's not full, but I still have many that I don't remember now. So, limb dropping test, eyelid release test, 4-glance inspection, things that I don't even remember anymore, that he used to just throw at, walking by. He will say, or I will read a book and it will say something about the exam. Anyways, so create your book, create something that you carry with you. Broom's nystagmus. I don't even remember that one. Okay, so carry something to make a note. I take a lot of notes on smartphone, but I think nothing beats these books if you have them around. I started collecting a lot of these small useful scales and tools and things like that. I used to get them, laminate them, so predicting stroke. This test, say the name of the color, not the color of the color, or and alternate that. So this is a neuropsychological test. You can find them and print them and keep them. MMSC, I used to carry that until eventually remembered. Test to Arno and lumbar puncture, I had the list of that. Blessed dementia scale. The Ray ostrich figure, I used to use that. Dr. Shaima was a big fan of this one. You guys, I don't know if you ever worked with Dr. Edward Shaima. He was an amazing general neurologist, one of the best I've ever seen. in my life. He knew everything about neurology. He was always reading these papers. So he used to read like 10 papers a day on neurology that were published. He will always have something, and he will bring something up, and he will listen to these audio CDs from A, and he would listen to every single lecture. I mean, he knew a lot. Verbal fluency test. So this is a full test, fast test. So we do just the F test. We don't do the A and the S, and it has the normative scores by age on what the score should be on F and A and S. So that's a full verbal fluency test. MOCA, but you know all of that. The Cretan cognitive testing, the trail A test, the full trail test, not the partial one we use on MOCA. It goes all the way to 26 and A to Z. The trails A, trails B, EEG figures. So we used to get these cards. I don't know if you get them anymore or not, where the different EEG pattern waveforms that you can carry in your pocket. So it was the epilepsy pocket card, the drug list, the dosing, and then phone numbers. Anyway, so it used to be much thicker than this, but I dropped out a lot of things with time. I used to carry these anti-epileptic drug cards, and then we had also then movement disorders, so you can have them pick up the color if they don't remember what medication they're taking. So okay, which pill does it look like? And they have different shapes. If they're brand one, just generic, then it becomes more complicated. But now I think there's an app. I've not gone to apps, but a lot of these things that I'm talking about, including OKN, is actually now available on the phone. You have apps for drug identification. You have an app for OKN testing that you can use. Parton sticks. I used to carry a lot of these. They are extremely useful for so many testing. And Dr. Bertoni used to use them a lot, but you can use them for fine touch, corneal reflex, nasal tickle, eyelid test. You can use them for root touch. You can use them to draw something in the hand. And then my best part is that you can break them, and it breaks into these sharp edges. We can do the sharp and soft on the same side. Does it feel sharp? Does this one, which one is dull, which one is sharp? You can do 2-point discrimination with them. They're both sharp. You can use the 2 in your hand and see, okay, can you tell it's 1 or 2, and see how far they can tell. And that varies, it's less than 1 millimeter on fingertip, but on the back it's about 1 centimeter. Have to be apart before you can tell there are 2 points and not 1 point each. And so on and so forth. You can do Babinski with these. These are, I think, the safest nociceptive sensation, or a broken tongue depressor. But tongue blade, somehow, towards my end of my residency, you couldn't find a tongue blade anymore on the wards, but these were still very common. So I used to carry a bunch of them with me. And light, I always believed in a strong light. So this was the strongest light I could follow. So if I really need to see these ICU patients which have these sluggish, minimal pupillary reflex, then I would take out this strong one and say, okay, do we really have a pupillary reflex here or not? Especially if you're getting like a request for brain death examination. Those patients have the most debatable pupils. So you're not sure which one to call it. Is it present? Is it absent? Is it sluggish? And then one trick I was told, which I think holds true, is that our eyes are more sensitive to the dilation back of the pupil, not contraction. So if you're not sure, and you put the light in, and you're not sure if it contracted or not, take away the light and keep looking at the pupil. And then if you will see it relax and dilate back, that means there was a pupil reflex, and now it's dilating back. And that I found very useful. There are many different things. There were these pinwheels you can use to check for where the level is for sensory for pinwheels, and tools like that. I used to collect a lot more. I lost them. I used to carry coffee beans in a glass vial for testing the sensory reflex. And then pocket cards. I really believe in these pocket cards a lot. You actually see that I had them printed on my standard notations on where I want to keep what. And in summarizing, I do them on these lists now that we get. But I used to have a pocket card because you can update them every day. It's in your pocket. You just take out and say, okay, platelet came back. This is 39 now. And as long as the patient stay in the ward, so for 7 days, 9 days, it will always be in your pocket. You keep updating it, have more room to it. The list is that you get a new daily printout every day. You throw the old one, and you get the new one. Now I don't care, but as a resident, I will have pocket cards. And even if I was the chief, then I have a card on every patient on my service for whoever is taking care of that patient. Doesn't matter. So these are some of the things that I still have with me that I used to use. Questions, comments? I have a lot of these cards that we carried. So there was the Neurology pocket card set, There was the epilepsy one, there was a stroke one that we used to have that I would carry in my pocket. They had useful references there. Questions, comments? Alright, let me just tell you a few of the apps I have on my phone that I found useful and I use very often. So there is this app. I don't know if it's some of these are still not they have not been updated, but the so one of this app that I'm still thinking about using it more often is called Face to Gene. Face to Gene. So if you take its face recognizing app that predicts I talk a lot about these facial malformations, right? Major malformations, major malformations, which is the intercanthal distance, the slope of the eyelids, the medial intercanthal versus lateral intercanthus, the height of the forehead, the smoothness of the philtrum, the U-shaped arch, the U-shaped teeth and the high arch palate, the low ear insertion, fusion of the external ear lobule. All of these are facial malformations, and that can be seen because of genetic defects. Usually it's not associated with monogenic defects, it's associated with the microdeletions or duplication. So if a significant part, 100 kilobyte or more is deleted, then it can end. The face is represented in so many chromosomes that many chromosomes, if they have microdeletion duplication, will have facial malformation. And then there's non-facial malformations like the hypoplastic fourth or fifth metacarpal. It's very common actually. That we don't look for it. If we start looking for it, it's actually very common. The way to look for that, the best way I found, is to compare it with your own hand. So if you match it like that, and then you see if their fourth or fifth finger are curving away from you, there's a mild curve, but if their curve is more steeper than your curve, then it means that they have the hypoplastic fourth and fifth. Assuming yours are normal, then if you have your hypoplastic fourth and fifth finger, then it's not going to work, but otherwise you can tell that the hypoplastic fingers are small. And then of course the palmar creases, you can look at them. There's the Sigan crease for down. You can look at the digits. Sometimes the most common one is that there is an extra joint in the thumb. Dr. Bertoni has had a patient with that. Also presented with a palatal tremor. So this Face to Gene app actually is trying to go even more deeper, and they are building this database which is cloud-based AI, which is learning what genetic malformations or deletions are associated with what facial features. So actually, if you think Dr. Torres has this FLF sign, funny looking face sign. So if you look at the face and say, there's something just not right about it. We are very sensitive to face. We have actually the biggest area of recognition in the occipital cortex is for face recognition. We're very sensitive to faces. So if you see a face and it just does not look right, FLF sign, funny looking face sign, then for fellows, movement disorder fellow, we have them describe the face, what is not right about the face, and I gave you some of those examples. There's also frontal bossing and so on and so forth, malar bossing can happen, the helix and anti-helix are not proportioned, loss of anti-helix, so on and so forth. There's many of those that would teach our fellows on what to look for face. But with this app, you can just scan the face and see if it fits with any genetic malformation. So Face to Gene app. Then there's the Pocket Eye Exam app. It has the most detailed options of all. It has the Ishihara plates, the Okian strip. This is a paid app, but it's not very expensive. Pupil chart, red desaturation. As I said, one of the earliest things in the optic neuritis is the loss of red saturation. Visual acuity test, the pupillary light reflex is present. And then Neurolocalizer is another one that gives you localization. It's more basic, but it can give you some idea. There is Medtronic apps couple that we use for tremor patients, Assess DBS app, and there's one more for Medtronic. AN has a couple of apps that I use that you can find on the App Store. I have my own app, Tap PD, that I use for finger tapping in Parkinson's. Vision test, NerveViz. NerveViz is an excellent app That app help you localize if this is the weakness, then which nerve is involved, which chord of the plexus is involved, which root is involved. So rather than remembering that, so nerve whiz, if you tap in which muscles are weak, then you can actually map the whole path for you. Which nerve is involved, which root is involved, which chord is involved in the plexus. So nerve whiz is very useful. In Parkinson's, we use this M-Power. M-Power test for tremors in their hand, bradykinesia with finger tapping, gait abnormality, and speech hypophonia. It can test for that. There is an Alzheimer's Association app, which is good for dementia, has a lot of dementia scales. Similarly, MS Society has an app, which has a lot of disability scales for MS built into the app. Stroke scale, so Stroke Society, American Heart Association has an app for stroke scale. So the NIH stroke scale pictures and words that you have to show to the patient, it's in that app. So if you don't have the cards with you, you can just open up the app and it will have all that. And then drugs, so that's the Micromedics app for drugs, and then iPharmacy. These two apps have drug identification. So if they say it's a red pill and it's small or big for epilepsy or whatever, and then you can look up that up and see which drug that might be if they're not remembering the name. And then of course Pocket Hippocrates is there. Pocket Cards is a paid app, but it has a lot of these cards that I was showing you. The General Neurology card, the epilepsy card with waveforms and patterns. They've actually built an app for it. It's called Pocket Cards. 3D Brain for description. This Neuro Toolkit that I use has a lot of scales in it. And then there are a couple of tremor apps that I use. iSeismometer and My Tremor app. iScore has various scores. NeuroMine has various scores that I have on my phone. And then there is those are medicine specific, and there are some general apps that I use for routinely. UNMC has an app that has a lot of useful things. Download that. That has useful maps and some other useful information there too. Most neurology society have apps that you can get. So AN has apps that you can find on the AN store. Movement Disorder Society has app. MS Society, Alzheimer's Association, Huntington's Association, Dystonia Research Foundation, all of these Parkinson's study groups, these have apps that you can find and you can explore to see if they have tools that you can use. And then of course there are many things you can use for productivity. I use a lot of Google productivity tools like Google Docs and Excel sheets available online. I dictate quite a bit now, a lot of things, if letter or something, I will just dictate. You can use a trick in Epic and use the Epic translation to translate that dictation for you. Otherwise, there are services that are AI-based services which can transcribe the audio for you, and the more you use them, the better they become. So I use Sonics for my transcription service, sonics.ai. It's an AI service that will take your audio recording and transcribe it into text for you. It's about 85% accurate for me, and I have a thick accent. It's probably better for if you're a native speaker. That I use very regularly, and I think that's about it for medicine. Any of you have any apps that you have used and found useful that you want to share?
MDCal.
MDCal. Okay, very good.
Neurosurgery survival guide's pretty good.
Okay.
Like dermatome maps, reflexes, some basic just neural learning.
Neurosurgery survival guide.
Yeah.
Stroke trials.
Stroke trials.
That's a good app. It's paid. It's only $5.
Stroke trials. You have summary of all the key trials in stroke.
All the key trials.
Yeah, it's a compendium of all the things. Neural toolkit is pretty decent. It's got stroke scale.
Yeah, I use that.
Yeah, okay. It's alright. It's got a tuning. Just have to keep pushing it.
So another app that I found interesting, it's probably more useful for patient, is called Blah Blah, BLAH, Blah Blah. So it's an app which basically has these cartoons on the screen, and you speak on the phone and the cartoons change, but they react to your volume. So it forces you or gives you a visual feedback that you're not speaking loud enough. So it was very useful for Parkinson's patient. You can, if they have hypophonia and they need something practice and they need feedback, that's one of the big job of therapists, give them feedback how loud they're speaking or not. So they can use this app, and then it's engaging. It forces you to, because it becomes funnier and funnier the louder you speak into it. It's called blah blah. BLA. So it was very interesting, but I know I tell my Parkinson's patient, a lot of them who have speech problems, to download this app and play with it, practice with it. There is a lot of app used by speech therapy people for communication. Maybe someday stop them and ask them if they recommend any apps. So there's a lot of communication apps. If someone had acute aphasia, then there are apps that can help them have pictures of common words or common things like water, glass, food, things like that, bathroom, so they can tap and it will speak out loud for them. That is useful for them. Cool. Any other questions, concerns, thoughts, ideas? All right, let's call it a day.